Welcome back into Talking Fitchburg. Joining in today from Fitch-Rona EMS, we have our medical director for Fitch-Rona EMS, and I have to look at this because I don't want to say it wrong. Like, man, Sarah, like...
That's right. You got it.
Can't you just have, like, Anderson, like, just simple? You're director... Yeah, common man, common spelling. Yes. We'll just go forward here and say Mike and Patrick are here in studio, but Dr. Mike's, just a little bit better here. Regardless, we kind of talked last time that we got together, we were talking about hands-only CPR classes. Those will continue to happen, and you can always get involved in that. But we also wanted to take the opportunity to talk about, we got into a little bit of data. You two are looking at data all the time, but more importantly, how our service looks at cardiac arrest calls in different aspects, and how that helps you in educating the public, educating your medics, following trends, and just picking your brain here a little bit about the data that comes in and how you guys look at it. So Patrick, first and foremost, you gave me like 200 reports here, and I'm surprised on a few things, but as you look at the reports in the last couple of years when it comes to cardiac arrest, how do you look at it as a director? So,
kind of as I mentioned last time we talked, I love the report card. Not nice thing about cardiac arrests, but they're fairly templated. Unlike some of those other patient presentations that can be a bit more challenging, when you come across a cardiac arrest, you immediately go to, there is an algorithm, right? If then, and you're presented with something, and this is the path we go down. So it's pretty, I don't want to say easy, but it is such a good thing that we can look at as far as, did we follow protocol? And protocols are truly based on the science, and these are all outcome-based measures, and we can look at them and go, are we doing the best care we can for these patients based on some really solid science? So in a partnership with the county looks at this county-wide and then puts that information statewide, national-wide. The county looks at every one of those and actually provides those metrics of things we've talked about, that public access CPR. Are we pushing hard enough? Are we pushing fast enough? Did we stay off the chest? What are we doing for airways, and what were those patients' ultimate outcomes? So probably because it lends itself to some easy quality assurance and little easy fixes of big one we look at. Very first thing I always look at is we don't want to be off the chest more than for 10 seconds ever. And that's always the first one that we look at is, and it is gigged to the point of you are off the chest one time for 10 seconds. It's a big red X. Like, right, we did not meet those metrics. So it's easy enough to share that with our EMS providers, our firefighters and our police officers, and say, it is really important to just keep pushing on that chest.
It's amazing that something so simple can have so many benefits. Why is that the case?
So with cardiac arrest, there's a few factors that really make a big, proven, meaningful impact. And those are the things that we care about. One of those things is, are you pressing on the chest, and are you doing it early on? That's the first basic step. So did you start CPR? Did you start it early? And did somebody else start it before EMS got there? Mm-hmm. Really one of those things that really can help make that lead to a good outcome. So we care about those factors that really lead to a good outcome, and that's kind of what we hone in on and say, hey, are we doing those things effectively? Are we doing them good enough? Do we have areas we need to improve? That's what we look at.
And for people outside of the EMS world who are looking at this like, okay, so you're telling me that you have all these tools in an ambulance. We've had all these great segments of all the stuff that is very crucial in doing it. But at the end of the day, I got to get on that chest and start pumping.
And that is part of what I share when I teach CPR classes. I'm like, right, you got a really expensive ambulance with a bunch of drugs and medications and some highly skilled providers in there. And that is a lot of stuff. That is responsible for essentially saving such a few number of people, when really it is very science-based, that says getting on that chest early, pushing appropriately, finding where that nearest AED is, and all of our Fitchburg officers, our Verona officers, Dane County officers, fire department, they all have AEDs. So getting that AED there very quickly, pushing on that chest quickly, like I say, gives us something to work with. Right? If they don't wake up after that first shock and say, please stop doing CPR on my chest, that's when we pull out the rest of the tricks and we start playing. I always call it doing chemistry inside patients' bodies, right? I'm going to give you medication to make your heart excited so that I can give you medication to make it stop. But really, right, the vast, vast majority of all those patients who survive have that CPR. You got to move that blood. You got to move that blood. And that is truly just getting on a chest and pushing.
And maybe talking outcomes after the patient gets to the hospital. Every patient's different. Every outcome is different. And there's highs and lows to all of this, too, on the timing, on when things kind of all come together. But once a patient hits the hospital, what could that treatment plan look like as they go through the system? But how do you take what you've got from that patient and bring that back to your medics and EMS services and say, hey, this really worked because this guy's or gal is going to be walking out of here, or there were other factors, but hey, you still did a great job.
Yeah, so once patient gets to the hospital, there are a lot of advanced things that we can do, but we need that patient to be at a point where they can receive those advanced level things. And in order for that to happen, those basic things need to have happened first. So that's kind of why we're emphasizing, hey, we got to get these things started early. So good bystander care, good EMS and pre-hospital care leads to good hospital care, leads to a good outcome. So that whole chain, we call it the chain of survival, that whole chain of survival, if all of those puzzle pieces are in place and all those things are aligned, that's what we look at for a good outcome. What we look at when we're reviewing cases after the fact is, hey, were there any areas in there that we could have done better on, or could have improved, or was there something that maybe we could have done a little differently, or is there some metric that we didn't meet? Most of the time, the good news is our metrics look really good. When the times we find something, hey, we could have done, this intervention earlier, we could have done CPR a little bit earlier, we could have had bystander CPR pressing on the chest before EMS got there. Those are the types of things that we look at to say, hey, how do we improve those things? How do we make an impact so that we can get to that good outcome?
As those numbers, as they come in, does that help you guys make decisions on, I mean, you have your protocols and everything, and protocols are, before I even say that, you can describe protocols here in a second, but you have all of these things that, again, you need it to, you use that education component is what I'm trying to say, to put together on top of what a protocols you're doing. I think the reassurance to the public is that you're always adjusting with a lot of factors in place to try to find the best outcome for whatever is thrown at you guys.
Sure, absolutely. So patient care protocols, right? It's a book that says if Patrick's having chest pain, all right, literally open the book to where it says chest pain, this is what we start. Now, it's not quite, I would say you could teach a monkey to do EMS stuff, right? It's not quite that.
Wow, this might come up in the review. Yeah, you don't say that in front of MD. Just saying.
Well, part of it is, right, here's the challenge, right? If it was that simple, right, Jeremy, here's the book, open it up to chest pain and proceed. Now, find me the one that says I'm having chest pain, shortness of breath, and pain in my left foot, right? There's no protocol for those three things. So that's where that critical thinking component comes in, is what exactly is going on here. But so we look at those, not even just us as Fitch-Rona, us as a larger county, state, wherever, every 2 years, and said, what does the science say? What are we doing right? As I mentioned in my last segment, have been doing this for a few years, right? The things I learned 23 some years ago, right, when I went to paramedic school, a handful of those drugs we don't even carry anymore. They looked at them and said, right, this doesn't really make a difference. Let's get rid of these handful of drugs we have added in there, and said, there's something new, there's something greater. It seems to be working. So we change and adapt those protocols. And then as it drives, as you kind of talked about, right, how can we get those survival rates higher? How can we make them greater? Did this person get public access CPR, right? It happened in a public place and nobody did anything. So what do we need to do? Let's get a class going in the city of Verona. Let's do a class at the library, right? Let's get more employers involved. Let's encourage employers to buy AEDs. Those are things that we can drive publicly that we can try to increase those survival rates.
And as far as, I'm going to take this a totally opposite way for a moment here, but as EMS keeps evolving and there's more things that keep getting added to the medic's plate, is it, short of being a doctor out there, they've got a lot of skills in the pre-hospital setting to make things work. Is that pretty reassuring for people that are out there, from your perspective as a doctor, waiting for patients to come in? Or maybe not wait, but they're coming.
No, absolutely. It makes me feel comfortable as a community member to know that we do have an EMS system that's really invested in having the right resources, the right tools to really provide the right treatment and give patients the best chance of survival. So I do feel comfort in that. And not only do we take that and make sure that they're trained and have all the adequate skills in terms of the tools and resources and equipment and medications. But then taking that beyond the education, just the providers, now hopefully kind of getting that message out to the public of, hey, there's other things we can also do to really help that in the process.
Yeah, I mean, there are so many things, like I think it basically teaching an EMS class out there, but hands-only CPR is such a great tool. And, you know, as we roll back into where we started here, final thoughts on just any of the data points that you guys are reviewing and have seen this past year that you're like, okay, because of this, we're doing this, or because of this, I need to train you on that.
I think, kind of as our last segment talked about, to me, I would really like to start targeting those underrepresented populations. As we kind of chatted earlier as well, that it's good for everybody. Right? The average, pulled that number out for right, Fitch-Rona, the mean age of a cardiac arrest that had a survival rate at Fitch-Rona was only 57 years old, 58 years old. Like as I'm sneaking up on that number, right?
Yeah, you kind of check yourself like
whoa, right? What's you know? So this is the much bigger picture of, you know, diet, exercise, healthy living. But that's such a young number, and we look at different male, female, and all of our the racial division or the racial makeup we have here in Fitchburg of this is such a skill we can get out to everybody, and as we mentioned, it's so easy to do. So that's those numbers for us. This year was actually a pretty good year, Dane County wide for us wide, and excited to see what we're going to do next year.
I think when I look at this, I am very pleased with how our trend of survival rates gone. We're actually in the top category within the nation, which is really something that our system, our county should be really proud of, and our community should be proud of that too. But again, looking for those things, any areas where we can improve and involve anyone else that can help with us, including the public, that's kind of what we're looking for. But overall, our survival numbers are really high for the categories that we look at, which is obviously a good thing.
Yeah, absolutely. Well, I think it's reassuring to have these conversations in public where behind the scenes, you guys are always looking at this. And it's not just in this cardiac arrest world. You're looking at across the gamma of incidents and continue to do the training and stuff. And I think it's top notch here in Fitchburg. Not just because I'm employed with the city of Fitchburg, but proven by the data and the education that you guys are doing at Fitch-Rona. It's pretty awesome. So. On that, thank you both again. Thank you, Doctor, for coming out. Absolutely. And we hope to have you back on the show. Patrick, we'll find you.
You know where I work.
Yeah, exactly.
Thanks, Jeremy.
Thank you, guys.